Imagine you're a doctor looking at a brain scan. Your patient has just had a stroke. And, well, you know you need to thin their blood to prevent another one from happening.
Right.
But here is the terrifying catch. Thinning their blood actively increases the risk of a catastrophic brain bleed. You are staring at this scan, you're weighing the options, and you just have to make that call.
Mm.
How do you possibly balance those scales?
I mean, it is arguably one of the most agonizing decisions in modern medicine. You are constantly walking a tightrope between two potentially devastating, life-altering outcomes.
Yeah.
And the margin for error is just, well, it's almost non-existent.
Exactly. And that is the mission of our deep dive today. We are going to decode this incredibly high-stakes medical balancing act of anticoagulation and intracranial hemorrhage, which we'll just refer to as ICH for risk management.
A very necessary abbreviation.
Right. We have this fascinating stack of medical case files and clinical transcripts detailing exactly how different blood thinners interact with the human brain.
And these files offer a really rare window into the messy realities of emergency medicine. I mean, they move past the pure statistics and actually show us the real-time thought process of physicians who are dealing with just unimaginable pressure.
Speaking of messy realities, we have an anchor case threading through all this data today. We can just call it case file 004. So a patient comes into the emergency room presenting with symptoms of a brain bleed, but there is this massive twist.
Oh, yeah. The neighbor.
Right. A neighbor who accompanied the patient casually mentions that the patient has actually been taking warfarin.
Which is a very powerful blood thinner.
Exactly. She's been taking it for years to manage an irregular heartbeat. And nobody at the hospital had confirmed this fact until that exact moment.
Which completely flips the script for the attending physicians. I mean, suddenly they aren't treating a spontaneous bleed. They are fighting against a medically altered circulatory system. And that behaves in a completely different way.
Okay, let's unpack this, because before we can even begin to understand how medications like warfarin cause bleeding, we have to understand what happens when the body's own internal clotting systems fail on their own.
Right, we need a baseline.
We need a baseline of how the brain bleeds when things go wrong naturally.
And to get that baseline, we can look at rare inherited bleeding disorders. So these are situations where the body's intrinsic ability to stop a bleed is compromised from birth or, through disease, entirely without any outside drugs.
I like to think of the body's normal coagulation cascade like a really complex line of dominoes.
That's a good way to look at it.
Yeah, like when you get a cut, you knock over the first domino, and it triggers this beautiful, intricate chain reaction that eventually forms a solid clot. But with these inherited disorders, it's like somebody reached in the middle of the line and just took a few dominoes out.
And when those specific dominoes are missing in the brain, the results are catastrophic. Take hemophilia, for example. Specifically, factor VIII deficiency. This condition causes an ICH in roughly 2.5% to 6% of patients. And most of those affected are young, usually under the age of 18.
Wow.
Yeah, and the mortality rate for that specific type of brain bleed is a staggering 65%.
65%?
Yeah.
For a teenager. I mean, that is just a devastating baseline to start from. Now, missing dominoes is one thing, but what happens if the body just doesn't have enough of the actual materials it needs to build the clot in the first place, like platelets?
Well, that brings us to immune thrombocytopenia. That's a condition where the patient's platelet count drops dangerously low. For context, a normal platelet count is usually between 150,000 to 450,000.
Okay.
Life-threatening brain bleeds occur in about 1% of these patients, but specifically when their count plummets below 10,000.
Below 10,000. So the dominoes aren't just missing. The whole table is essentially collapsing at that point.
Exactly. And then you have situations where the blood cells themselves become malignant, like in leukemia. Certain leukemias disrupt this fragile system entirely.
Like which ones?
Well, acute lymphocytic leukemia, for instance. It has a tendency to cause bleeding in the lobar white matter of the brain, and that's usually alongside systemic bleeding in the gastrointestinal tract or mucous membranes.
Okay, wait, let's keep it simple for a second.
Why?
When you say lobar white matter, what exactly are we talking about in terms of the brain's geography?
Oh, good question. So the brain has gray matter on the outside, right, which does the processing, and white matter on the inside, which is like the deep connective cabling that sends signals across different regions.
Oh, I see.
Yeah, and this specific leukemia attacks those deep internal networks. It happens when you have a really dangerous combination of low platelets and a massive spike in abnormal white blood cells.
It sounds awful.
It is. Then you have acute promyelocytic leukemia, which causes brain bleeds through a condition known as DIC, or disseminated intravascular coagulation.
DIC. That just sounds incredibly ominous. What is DIC actually doing to the blood?
Essentially, the clotting system goes totally haywire. The body starts forming these tiny clots everywhere inside the blood vessels, and that uses up all the available clotting proteins and platelets.
Wait, so it uses everything up, making useless clots?
Exactly. And because all the supplies are exhausted, the patient paradoxically starts bleeding heavily from everywhere else, including the brain.
Wow.
These inherited and disease-driven failures are rare, but they show us the terrifying ceiling of what happens when the brain's chemical environment is compromised.
Which sets the stage for our main event. Because understanding how these intrinsic failures work tells us exactly what we are risking when we purposely alter the blood with drugs.
Right.
Let's look at warfarin, since that is exactly what the patient in case file 004 was taking. Warfarin is a vitamin K antagonist, and the numbers attached to it are, well, they're sobering. It raises the risk of an ICH 2 to 4-fold compared to similar patients who are not on anticoagulants.
Yeah, 2 to 4 times the risk is substantial. In fact, anticoagulant-related bleeds account for 9 to 14% of all ICH cases. That is a massive chunk of all brain bleeds.
Before we dive deeper into the stats, why vitamin K? Like, what does antagonizing vitamin K actually do to that line of dominoes we talked about?
So vitamin K is essentially the activation switch for several key clotting factors that are produced in the liver. Without it, those specific proteins never mature into their active form.
Okay.
So by giving a patient a vitamin K antagonist like warfarin, you are systematically disabling several crucial dominoes in the cascade. It makes it much, much harder for the blood to clot.
But the risk isn't evenly distributed among everyone taking the drug, right?
Yeah.
The data points out several compounding risk factors, like advanced age, hypertension, prior stroke, head trauma, and concurrent use of antiplatelet drugs.
Yes, all of those multiply the danger.
And there is also a higher risk noted for patients of East Asian, Black, and Latin American ethnicity. But the single most dominant factor driving this risk comes down to 3 letters, the INR.
The INR, or International Normalized Ratio. This is the standardized blood test that measures exactly how long it takes for your blood to clot compared to a normal, unmedicated person.
When researchers actually looked at patients maintained at a higher INR, specifically between 3.0 and 4.5, the data was staggering. Out of that group, there were 24 ICH events, and 14 of them were fatal.
14.
Yeah, and they compared that to a group taking just daily low-dose aspirin. That aspirin group had only 3 ICH events, with just 1 fatality.
The contrast is undeniable.
So I have to push back here. If the numbers are this scary, if bumping the INR up to that 3.0 or 4.5 range causes 24 brain bleeds, why do we use this drug at all? It feels like we are handing people a ticking time bomb and just hoping it doesn't go off.
What's fascinating here is the incredibly strict math of prevention. The medical community didn't look at that trial and abandon warfarin.
They didn't.
No, they looked at it and realized that tight INR control is the absolute key to survival. That exact trial data is why the target INR for secondary prevention is kept rigidly between 2.0 and 3.0.
That is a microscopic window.
It really is, but keeping the patient exactly in that 2.0 to 3.0 range, meaning their blood takes 2 to 3 times longer to clot than normal, is one of the most powerful tools available.
Because it balances the scales.
Exactly. It is just thin enough to prevent the clot that causes an ischemic stroke, but just thick enough to minimize the risk of a fatal bleed. It requires immense ongoing vigilance.
The sheer numbers are terrifying, but let's shift to what this actually looks like in practice.
Yeah.
Because an anticoagulant bleed doesn't look or feel like a normal bleed.
No, it behaves in a fundamentally different way.
Here's where it gets really interesting. Because we need to talk about the tempo of a bleed. When we think of a standard hypertensive brain bleed, like one caused by high blood pressure, it is rapid. It is explosive. It's like a high-pressure pipe suddenly bursting inside your wall. The damage is immediate and catastrophic.
The vessel simply gives way under the sheer mechanical force of the blood pressure.
But an anticoagulant-related bleed, like from warfarin, has a genuinely distinct pattern. It progresses slowly, over 48 to 72 hours.
Right.
It's not a burst pipe. It is a massive, slow, unstoppable leak behind the drywall. You might not see the damage right away, but it just keeps seeping and spreading. Why does it act like that?
Think about the mechanics of it. With a warfarin bleed, the initial injury might just be a tiny micro tear in a small blood vessel. Normally, your body would patch that instantly.
The dominoes would fall.
Right. But because warfarin has permanently delayed the blood's ability to create a solid patch, that micro tear just keeps oozing. The structural integrity of the vessel isn't completely blown apart like in a high-pressure burst. It's just that the biological sealant is defective.
And because it spreads so slowly and relentlessly over days, the resulting hematomas, those pools of blood in the brain, end up being much larger on average.
Unfortunately, yes.
And that larger size is exactly why the mortality rate sits right around that grim 65% mark we saw earlier with hemophilia. It is an isolated, expanding disaster within the skull, rarely accompanied by bleeding anywhere else in the body.
Which brings us right back to the patient in case file 004.
Yes. The neighbor noted that the symptoms crept in over several hours, rather than happening in one dramatic instant.
And that temporal detail is a massive clue. If you are the emergency physician listening to that neighbor, alarm bells are ringing immediately.
That tempo alone is often enough to suggest anticoagulant involvement before a single lab result even comes back. The doctors can hear the clock ticking just by listening to the patient's history.
Absolutely.
Because warfarin is such a blunt instrument causing these slow, deadly bleeds, modern medicine eventually went looking for safer alternatives, which led to the DOACs, direct oral anticoagulants.
And randomized trials consistently show that DOACs genuinely carry a lower ICH risk than warfarin in patients with non-valvular atrial fibrillation. It represents a real reduction in danger, not just some pharmaceutical marketing claim.
The mechanism for why they are safer brings us back to our domino analogy. Warfarin is like taking a shotgun to the domino line. It knocks out 4 separate vitamin K-dependent factors simultaneously, shutting down multiple potential pathways. But DOACs are like a sniper rifle.
That's a great comparison. They target a single specific point in the coagulation cascade, usually either factor A or thrombin. By only disabling that one specific domino, DOACs still allow a robust hemostatic response through other alternate pathways in the body.
So the body can still somewhat patch things up if a tiny vessel tears.
Exactly.
But of course, nothing is ever that simple in neurology. Because as our MRI imaging technology gets more advanced, doctors are starting to see these things called microbleeds on patient scans. And that complicates the use of any blood thinner.
Oh, cerebral microbleeds present a tremendous clinical dilemma. These are small areas of prior bleeding in the brain. Pathologically, they are deposits of hemosiderin-laden macrophages, usually reflecting underlying issues like hypertensive arteriopathy or amyloid angiopathy.
Okay, let's keep it simple for a second. Break down that terminology. What exactly is amyloid angiopathy? Are we talking about proteins building up in the brain?
Yes, exactly. Amyloid angiopathy is a condition where rogue proteins, called amyloids, build up in the walls of the small blood vessels in the brain. It makes them brittle and prone to cracking.
And what about hemosiderin-laden macrophages? What does that actually look like?
Well, macrophages are essentially the cellular cleanup crew of the immune system. When a tiny bit of blood leaks out of a brittle vessel, these cells arrive to clean it up. But the red blood cells leave behind iron.
Okay.
So you get these tiny pockets of iron deposits left over. It is quite literally biological rust left behind after a microscopic bleed. When a patient is placed on anticoagulants, the presence of this brain rust independently raises their risk of suffering a major hemorrhage.
I have to challenge this logic because my basic common sense is screaming right now. Put yourself in the shoes of a neurologist. You are looking at an MRI and you see visual evidence of tiny bleeding already happening in your patient's brain.
Right.
Instinct says, absolutely do not give them a drug designed to make them bleed more easily. But clinical guidance tells doctors to ignore that instinct. Why?
Because you have to zoom out and look at the whole equation. It feels completely counterintuitive, I know, but automatically withholding anticoagulants from a stroke patient purely because they have microbleeds is a recognized clinical pitfall.
But they are actively bleeding, even if it's microbleeding.
They are, but you have to trust the math over the visual fear induced by the scan. In patients with an established need for a blood thinner, like those with atrial fibrillation, where blood pools and clots in the heart.
Right, they need the meds.
Exactly. The absolute probability of suffering a massive, debilitating ischemic stroke from a traveling clot far exceeds the risk of triggering a brain bleed. The ischemic benefit generally outweighs the bleeding risk, even with a high burden of microbleeds.
So you just have to override your own visual panic, look past the rust spots on the MRI, and trust the long-term statistics.
Yes.
That takes an incredible amount of clinical discipline. Now, we've talked about preventing strokes and the risks of long-term daily pills like DOACs, but what happens in a terrifying acute emergency? Like when someone is actively having a stroke right in front of you and doctors administer intravenous clot busters.
You're referring to thrombolysis, specifically drugs like IV alteplase. In those acute emergencies, the medication is designed to aggressively dissolve the clot, blocking the brain's oxygen supply.
The side effects are severe. In the pivotal trials, IV alteplase caused symptomatic ICH in 6.4% of cases.
Yeah.
To put that in perspective, that is 10 times the rate seen in the placebo group.
It's a huge jump. And if the medical team uses intra-arterial thrombolysis, where they thread a catheter directly into the artery to bust the clot at the source, the hemorrhage risk climbs even higher to around 11%.
11%.
Yeah, and those bleeds often occur right at the site of the original dead tissue and carry a very poor prognosis.
The risk factors for this complication are common too. A severe initial neurological deficit, high blood sugar, elevated blood pressure, and something called hypodensity on the CT scan.
Hypodensity simply means a dark spot on the scan, which indicates that the brain tissue in that area has already died or is dying from a lack of oxygen.
Right.
When you suddenly flood that damaged, fragile tissue with high-pressure medicated blood, the compromised vessels often just rupture.
It highlights how violently delicate the brain's vascular system becomes during an emergency. But perhaps the most complex dilemma in all of this data is what happens after the emergency.
The ultimate paradox.
If a patient actually survives an ICH, if they beat that 65% mortality rate, do you ever dare put them back on blood thinners?
Yeah.
It sounds like outright malpractice to even suggest it.
It really does sound like madness. But researchers investigated this deeply in the RESTART trial.
I had to read the statistics for this trial 3 times to make sure I wasn't misunderstanding them.
It's shocking data.
The researchers took survivors of an ICH who had a separate, valid medical reason to be on antiplatelet therapy, meaning they needed medications that stop blood cells from clumping together, usually to protect their heart.
And the researchers randomized these brain bleed survivors to see what would actually happen if they restarted their antiplatelet medication versus keeping them off it entirely.
And the result completely defies expectations. Restarting antiplatelets did not increase the risk of a recurrent ICH.
No.
Giving a blood-thinning agent to someone who just survived a brain bleed did not make them more likely to bleed into their brain again.
It didn't, and the benefits were substantial. Restarting the therapy produced a 35% relative risk reduction in a combined outcome of non-fatal heart attacks, non-fatal strokes, and vascular death.
But the most staggering detail is this. There was a non-significant trend toward less recurrent ICH in the group that restarted their antiplatelets. Less. So what does this all mean? How is it physically possible that a medication that inhibits clotting could somehow protect a brain bleed survivor from bleeding again?
If we connect this to the bigger picture, it reminds us that human physiology is vastly more complex than simple plumbing. We tend to think thinner blood equals more bleeding.
Right, it's intuitive.
But the biological systems repairing those damaged vessels, managing local inflammation, and preventing microscopic clots are incredibly intricate. It is entirely possible that by preventing microclots, the therapy actually improves the overall health and healing environment of the vascular system.
The clinical files note that this result was genuinely surprising, and the exact mechanism is not yet fully explained.
Which is exactly why large, randomized trials are still underway, particularly for restarting full anticoagulation in atrial fibrillation patients who survived an ICH.
We need more data.
We do. We can look at observational registries all day, but they are full of confounding variables, like doctors only giving the drugs to their healthiest patients. Only massive randomized data can cut through the noise and give us the clinical truth.
Which brings us back to the overarching theme of this entire deep dive. Managing this field of medicine is quite literally a high-wire act of treating the stroke while respecting the bleed.
Beautifully said.
You have to rely strictly on hard data and mechanisms. You have to respect the strict mathematical boundaries like the 2.0 to 3.0 INR target.
Yeah.
You have to ignore your own visual panic when seeing microbleeds, trusting that the stroke risk is mathematically higher.
And you must never assume that the obvious intuitive answer is the correct one, as the RESTART trial so clearly proved.
As for our anchor patient in case file 004, her symptom onset was a slow, unstoppable leak over hours. The classic tempo of a warfarin bleed. The case file ends by noting that her INR blood test result is urgently pending.
Yeah, that's the cliffhanger.
That single number, that exact measurement of how thoroughly her abdominal line has been dismantled, will dictate her fate and exactly what the medical team does next.
It all comes down to understanding the tempo and trusting the test.
Before we wrap up, there is one final mystery buried in these clinical files that we haven't resolved, and it is a complete head-scratcher.
This raises an important question regarding the DOACs. We explored how their sniper rifle approach makes them generally safer than warfarin. And the data explicitly states that DOACs result in smaller baseline hematoma volumes when a bleed does eventually occur.
Right.
Furthermore, patients on DOACs present with lower admission stroke severity scores than patients on warfarin.
Right, so their brain bleeds are physically smaller on the scan, and their clinical symptoms are noticeably milder when they first arrive at the hospital doors.
Yet the data unequivocally shows that once a DOAC-related ICH actually happens, the mortality rate does not clearly differ from a warfarin-related ICH.
That is wild.
It is. Despite the smaller bleed and milder symptoms at admission, both groups still hover around that grim 65% mortality mark.
And that is what I want you to think about as we sign off. If a patient comes into the emergency room with a physically smaller brain bleed and milder stroke symptoms simply because they took a DOAC instead of warfarin, why is their chance of dying exactly the same? What invisible, deadly cascade is happening inside the brain after they are admitted that completely levels the playing field? We started by asking you to imagine being a doctor looking at a scan, trying to balance the scales. It turns out even when the scan looks better, the scales are just as heavy.